Hi, my name is Pradeep Natarajan. I'm the Director of Preventive Cardiology at Mass General Hospital in Boston, Massachusetts. The focus of my clinical work and my research work is to understand the genetic basis of premature myocardial infarction that often involves genetic testing and often involves the evaluation of blood lipids. So today's key takeaways are to understand the common terminologies used to group humans in the biomedical literature, to recognize the heritable and molecular basis of familial hypercholesterolemia, and to identify the clinical role of familial hypercholesterolemia genetic testing. First, it's important to run through definitions of race, ethnicity, and ancestry, as these are often used in the biomedical literature and oftentimes interchangeably. So race and ethnicity are dynamic. They're shaped by geographic, cultural, and sociopolitical forces. Importantly, race and ethnicity have no biological meaning and generally refer to major groupings of humans connected by common descent or origin, and often have distinct physical features. But importantly, external determinations purely based on physical features can often propagate racism. Ancestry is a related concept. It refers to a person's country or region of origin or an individual's lineage of descent and can be quantified using genetic procedures. So early in the 1900s, it was increasingly recognized that individuals were succumbing to complications of atherosclerotic cardiovascular disease, namely myocardial infarction, increasingly occurring in younger individuals. Some of the earliest analyses of this phenomenon actually occurred in Boston, Massachusetts, a key partnering between Dr. Samuel Levine at the Peter Bent Brigham Hospital, now Brigham and Women's Hospital, and Dr. Paul Dudley White at the Mass General Hospital. Together with the cardiology fellow, they ascertained a set of cases of individuals who were succumbing to premature myocardial infarction, as well as controls, and they found two key features. Individuals who had premature myocardial infarction often had elevated blood lipids, and they also happened to have family members who often also had premature myocardial infarction and who also often had hyperlipidemia. A significant amount of work in the 1930s through the 1950s focused on ascertaining such families that were exceptional, enriched for premature myocardial infarction as well as hypercholesterolemia. A term, familial hypercholesterolemia, was coined for such individuals. It was observed that there were individuals who had very elevated lipids and premature myocardial infarction, and particularly in families where there were marriages among closely related individuals, there were often individuals who had extremely elevated lipids and were getting myocardial infarctions in childhood. A significant amount of work in the 1960s and 1970s identified the molecular basis of familial hypercholesterolemia. This ultimately led to a Nobel Prize in the 1980s to Dr. Michael Brown and Dr. Joseph Goldstein. The vast majority of individuals with familial hypercholesterolemia had disruptions in the LDL receptor gene. Now, the LDL receptor sits at the cell surface of liver cells, is involved in the clearing of cholesterol, usually through the endocytosis of LDL particles. Now, individuals who have disruptions of the LDL receptor are unable to clear LDL cholesterol. The liver senses that there is actually not enough LDL cholesterol around because it's not endocytosing the LDL, and the liver starts overproducing cholesterol. And so these individuals continuously overproduce LDL cholesterol, are unable to clear it, and are consequently at very high risk for cardiovascular disease. Now, in the world, the prevalence of familial hypercholesterolemia is 1 in 250. Pretty similar across most countries and across most groups. There are key groups, particularly groups that have undergone a founder effect, meaning a small number of individuals who had started a population, or a bottleneck, where there are external forces also funneling to a small number of individuals who then propagate a group. In these groups, the prevalence of familial hypercholesterolemia variants are even higher. In Northern Europe, Lebanese Christians, South African Afrikaners, Ashkenazi Jews, South African Indians, French Canadians in Northern Quebec, Old Order Amish, and individuals in Tunisia. Now, there are clinical criteria to help identify individuals who may have familial hypercholesterolemia. There are a few. One of the most widely used is the Dutch Lipid Clinic Network Diagnostic criteria. They're binned across a few categories, including the personal history of the patient, their family history, as well as physical exam features, if there are significant elevations in blood lipids, as well as if there may be any genetic testing involved. And then, based on the score, one can identify the likelihood of that individual having familial hypercholesterolemia. Now, when paired with genetic testing, there are actually a lot of individuals who have high clinical features indicative of familial hypercholesterolemia who are negative by genetic testing. The vast majority of the genetic variants occur in the LDL receptor, also in a region of the apolipoprotein B gene. That's the key protein determinant of the LDL particles, and particularly in the domain that binds with the LDL receptor. But you can see, even individuals who are probable familial hypercholesterolemia, only about 1 in 6 are positive through genetic testing. Even individuals who have an overwhelming number of clinical criteria, as indefinite familial hypercholesterolemia, it's only 1 in 4. Now, what does that mean? That implies that there are likely other genetic determinants that are influencing severe hypercholesterolemia outside the realm of the typical familial hypercholesterolemia genes. And importantly, there are a variety of lifestyle and environmental influences that increase the likelihood of severe hypercholesterolemia. Now, what's the value of genetic testing if in the end we're going to be treating the causal biomarker LDL cholesterol? It turns out for a given LDL cholesterol, knowing whether that mechanism to get to that LDL cholesterol was through a familial hypercholesterolemia variant, that substantially discriminates risk. Individuals who have even more moderate hypercholesterolemia, in the 160s to 190s, having a familial hypercholesterolemia variant get to that level substantially elevates risk. We think that the mechanism for that heightened risk is that individuals who have genetically determined significant hypercholesterolemia have very high LDL cholesterol levels from birth into childhood. And LDL cholesterol has a cumulative effect in the development of atherosclerosis and atherosclerotic cardiovascular disease events. So that is why for individuals it's important to check lipids early to ensure that we break the process early and prevent the compounding exposure. Now, genetic testing was actually only recently introduced in the practice guidelines for cardiologists. That is because in our armament was largely statins up until the late 2010s. The latest cholesterol guidelines from the American College of Cardiology and the American Heart Association, it has been well recognized for decades that individuals with severe hypercholesterolemia, so LDL cholesterol greater than 190 milligrams per deciliter, are eligible for statins and should be tolerated on the maximum tolerated statins. The goal cholesterol lowering is at least 50% lowering for LDL cholesterol. If they don't achieve that goal, then adding in ezetimibe. Now, individuals who still have an LDL cholesterol greater than 100, if there is evidence for familial hypercholesterolemia and they don't have cardiovascular disease, that is when more expensive medicines such as PCSK9 inhibitors would be indicated. Now, who to do genetic testing on? There was a recent consensus document convened by the Journal of the American College of Cardiology that basically indicated that it's important to recognize familial hypercholesterolemia early in individuals because it has familial benefit. So if there are any clinical features that are supportive of familial hypercholesterolemia, genetic testing is appropriate to consider. And most importantly, there are individuals for whom practice management may change, particularly for the escalation of therapies. A word on the testing itself. The typical technology used for genetic testing for familial hypercholesterolemia is called sequencing. That's where we take an individual's LDL receptor gene and enumerate every single base pair and see if there are individual variants that may predict the disruption of the LDL receptor. Those genetic variants may be private to that given individual. Now, there are direct-to-consumer testing technologies used to look at genetic variation as it relates to health and common human traits. There are genetic variants that are captured for LDL receptor, but the technology used is array technology, so that it's a set of pre-specified genetic variants that are more commonly observed in the general population. As a result, the diagnostic yield through that approach for familial hypercholesterolemia and most Mendelian conditions is incomplete. There's substantial biases as far as the diagnostic yield by ancestry as well, particularly with underrepresented minorities not having as many of the genetic variants for familial hypercholesterolemia represented on that array technology. So those arrays are specific if a genetic variant is determined, but if it's negative, it does not rule out familial hypercholesterolemia. So in summary, clinical genetic testing for coronary artery disease is currently focused on familial hypercholesterolemia diagnostic testing. Familial hypercholesterolemia is common worldwide and more common among key ancestral groups. Familial hypercholesterolemia genotypes carry excess coronary artery disease risk beyond lipids, and testing should be offered when suspected. Familial hypercholesterolemia genotypes may prompt more intensive lipid-lowering therapy and serve as an opportunity to lower risk in the whole family. Thank you for watching. I hope you found this educational video helpful.